Our next session will be on rhinology. The moderator, Dr. Amitabh Roy Chaudhary, sir. Uh, and the panelists are Dr. Doipan Mukherjee, Dr. Sanjay Ghosh, Dr. Moinak Dotto, Dr. Ravi Hembram, and Dr. Shubhabrata Sengupta will not be there. Dr. Debabrata Das will take the replace him.
Good morning to all from our team of Rhinology.
Good morning. So right now we will start nasal case. So after the ear cases, one of the most important part for your practical examination will be the nasal case. Why? Because as you all know, bulk amount of marks are dedicated for long case and short case. So any nasal case, maybe it's a nasal polyposis or nasal mass or tumor, can be given as long case or as short case. So that means ear case and nasal case. In your practical examination in any center, you will get these two cases either as long case or short case. This is for sure. Now, this is a structured one framed by Dr. Amitabh Roy Chaudhary, the case presentation, then CT MRI, then specimen, and then interaction. So, when you will proceed for the nasal cases, your approach will be also like that. First, the examiner will ask about the case. That is important part will be catered by Ravi Hembram, because until and unless you have presented your case in a proper manner, the further examination will not be proceeded. So the first part is very important, and this CT and MRI part of nasal diseases are important for your long case, short case, and also for the radiology section. And the specimen part is also very important for the long case and also for the specimen part. And lastly, we will have this interactive session. So without wasting any time, I will like to request Dr. Ravi Hembram to proceed for the case presentation.
Thank you. Ravi, please come here. So I will, because we are also running little behind schedule, so I will quickly in 2-3 minutes take you through a case capsule, and then Dr. Ravi will take you through the history taking and as the sequence described by Dr. Doipan. So we are going to discuss a 52-year-old female who is a housewife. Very short history because we have to discuss all the aspects. With the chief complaint of right-sided nasal obstruction for 1.5 years, right-sided nasal discharge also for 1.5 years. It is insidious onset. I think all these factors, all these things that needs to be taken in the history will be discussed by Dr. Ravi. And there is also associated symptom of intermittent bleeding, watering from the right eye for the same duration. On examination, we could see a right nasal cavity is completely blocked with a polypoidal looking mass, but the surface is irregular and variegated and presenting at the nostril. So obviously there is nothing could be seen in the into the nasal cavity. It does not bleed to touch. Probing is not possible because it is presenting at the nares, and oropharynx and palate NAD, which is very important. I think Ravi will discuss that. There is no proptosis. All these points will be discussed. And eyeball movements and visual acuity normal, and bilateral TM normal, and no palpable lymph nodes. This is the scan. We will discuss the scan later on, but this is the scan, MRI scan, where you can see there is a unilateral nasal mass, and in the coronal scan also you can see filling the right nasal cavity. And all these heterogeneity, homogeneous issues will be discussed by Dr. Moinak later on. Just for you to understand that this is a unilateral nasal mass presented by a 52-year-old lady who is a housewife, and this is the coronal image where you can see everything. The CT scan is not here. We will discuss the relevant scan finding. Over to Ravi.
Thank you, sir. Good morning. A very sincere pronoun to my respected teachers. So, history taking an examination of a case of nasal mass in right nasal cavity. So this is the most dreadest, fairest thing in your life. So examiner will sit in front of you and ask, what is the long case? You may answer first. It is ideally to answer the case summary first. Otherwise, your examiner will ask specific one. So this is the flow chart. This is the flow chart, and you are just sitting in front of your examination at provisional diagnosis part. So look in provisional diagnosis part. So anything, any question, at least 20 to 30% question asked from this provisional part, provisional diagnosis part, and the answer will be came from your history and clinical examination. So this is the importance of the history taking and clinical examination. I think rest of the thing will discuss by our other faculty. So first of all, patient demography. Name, age, sex, occupation, religion, everything has its own importance. Name, age, and age also in case of some diseases are appear in early age group, and some diseases are appear in late age group. And sex also importance, like some diseases are more predominant in male and female. Occupation, occupation also important, as because there is some occupation that that give rise to some problem in the nasal cavity. Religion, address, and socioeconomic status. So these are the whole chief component of any nasal diseases. So starting from the nasal obstruction, nasal discharge, bleeding from the nose, disturbance of smell, changes of voice, sneezing, headache, facial pain, cough, hawking sensation, and snoring. These are the main chief complaint. So it should be elaborated in your present illness part, history of present illness. So it's how it should be elaborated. So in case of nasal obstruction, the history of present illness will be like that. Laterality, whether it is unilateral or bilateral. So every point has its own importance. Mind it. Unilateral, DNS, AC polyp, foreign body, neoplasm, these are the diseases that may appear in unilateral cases, and bilateral. Along with duration, duration of the disease, whether it is long standing or chronic or acute in onset. Severity, whether it is persistent, intermittent, or aggressively severe, progressive. Progression of the disease, progression or non-progressive. Association with any climate change, aggravating factor, seasonal changes, relieving factor, whether and drug induced. So these are the things that you keep your mind during taking any nasal obstruction history. So it should be surveying by this all these points. Now coming to the second point, nasal discharge. So again, it can be right in this way, starting from the duration of the discharge, whether it is unilateral or bilateral. Some cases of, in case of children, there is a unilateral foul smelling nasal discharge will come. May likely to be have any foreign body or AC polyp, infected AC polyp, rhinosporidiosis. These are unilateral. There is some disease or bilateral allergic rhinitis, chronic rhinosinusitis. Again, coming to the character of the discharge, it may be watery. So CSF rhinorrhea, eosinophilic rhinopathy, all these present as watery rhinorrhea. So again, there is some differentiating point that come under the clinical examination. So how you differentiate from the CSF rhinorrhea to mucoid type of discharge. So there is handkerchief test is there. So mucoid. Second is mucoid. Third, purulent bloody discharge, blood-stained discharge, and thick discharge. There is some disease that causes thick discharge, genetically linked disease, cystic fibrosis cartilaginous syndrome. So this patient again causes some other disease also in lung. There is involvement of lungs, parenchyma also. So all the mucosa that have ciliary activity, that will get disturbed. So next, foul smelling, whether the discharge is foul smelling or not. In case of foreign body, atopic rhinitis, sinusitis, in case of infected severely purulent sinusitis causes foul smelling discharge, crusting. Second is, another is crusting. Atopic rhinitis granulomatous disease causes some sort of crusting inside the nose. Now Third is epistaxis or bleeding from the nose. Again, it can be write in your exam paper in duration, whether it is spontaneous or not, severity, whether mild, moderate, severe or not, history of trauma present or not, bleeding from other sides or not, whether it is from the one nostril or other nostril, any family history present or not, some kind of disease that is genetically run throughout in family, familial X-linked disorder, and history of bleeding disorder, history of drug intake like aspirin, warfarin, and addiction history. So causes of epistaxis, these are the some causes that may you all know all these causes: idiopathic, local causes like traumatic vasculitis, gallbladder disease; systemic causes, hypertension, liver failure, vitamin K deficiency, and puberty, pregnancy. So yes, sir.
I'll interrupt at this stage. Like when you are presenting the chief complaint of the patient, as Dr. Ravi said, you have to have kind of the examiner, when they cross the long case, there are two types of situation that can happen. Sometimes the examiner will complete your long case completely, then the crossing starts. And sometimes from each point the examiner starts crossing you. So unilateral nasal obstruction, as this lady had. So then the question will come, what are your suspicion regarding unilateral nasal obstruction? Then the discharge, as Ravi said. So again question will come that if there is a blood stain discharge in a unilateral nasal obstruction in a 52-year-old lady, what is your suspicion? That is how you should go to a deduction. The algorithm should be developed like this. This is what we are trying to, you all know these things, but we are trying to emphasize that how to judiciously present a long case and how to come to a deduction of a diagnosis going through a scientific algorithm and using your brain also.
Now, disturbance of smell, whether any disturbance of smell present or not, in this case there is no disturbance is there. So these are the causes that is found, there is some smell disorder. Now, change of voice present or not, if the tumor is encroached towards the tumor or anything encroached to the nasopharynx, that causes change of voice. It may be rhinology, apata or cloaca. Apata means there is opening, there is a hypernasality of the voice. So facial pain or headache, it may be there due to the obstruction of the sinuses and sinusitis. So these are the some causes, whether it is again bilateral or unilateral. In this case, this is unilateral, and severity, there is not severe, duration and radiation, whether any radiation taking or not. So these are the things that you should keep in mind during taking your case. So history of present illness. So all these things you have to write in your history. So whether this is sudden onset or gradual onset, progression, duration, intermittent or continuous discharge, associated symptoms like sneezing, postnasal bleeding or facial deformity. So this is all about your history of present illness. Now coming to the past history. So history of allergy, asthma. Yes, sir.
So once again, once you have done the history of present illness after chief complaint, you are gradually coming to a suspicion of a diagnosis. This particular patient profile with that duration, these are the symptoms. So with a 52-year-old lady, housewife, why is it important? Not any occupational dust exposure, because unilateral nasal mass can be malignant, and malignancy is common in a woodworker and all these things. So that is important in this case, occupation. All cases will be different. In case of exposure to pollens and dust, if there is a benign case, it will be relevant. So that's how you should then start thinking and presenting in your mind, because questions will come from how you present your case, not how the patient has presented. How you have framed your case, like a legal fight in the court, how you have framed your case, the judge will question. Here also it is the same thing. So you should practice that very well.
So, most important is the important negative history should be there in your long case. Otherwise, you cannot diagnose a cannot write a provisional diagnosis. So, past history is important. Past history, comorbidities, previous trauma, you should look for. and personal history, smoking, occupational exposure, environmental exposure, and drug history should be taken. Family history, is there any family history of same disease or not? Genetic syndrome present or not? And then coming to the general examination. So in general examination, patient alert, conscious, oriented, pallor, clubbing, cyanosis, and you should look for all these things. You should write in proper way so that if your examiner can ask you any question from any part of your provisional diagnosis, so that you can answer. So these are the protocol. So you should maintain all these things. Examination of the neck gland, neck vein, skin condition of the face, neck. This is also important in this case. So looking for any systemic sign or malignancy. So now coming to the local examination. So local is again it is divided into inspection, palpation, percussion, and auscultation part. Inspection, for inspection of the external face and nose. Any deformity, swelling present in front of the nasal nose and nasal dorsum or nasal ala, or any visible mass present or not, any changes of color, skin, or any sinus tract, fistula or dorsum present or not. So in this case, there is no such, only external deformity is present, mild. On palpation, you should palpate, you should confirm your inspectory finding in palpation, like tenderness, or in our in ENT, there should be some extra test, that is tenderness of the sinuses, to check the tenderness of the sinuses in palpation, mobility of the muscles, or any bony expansion or destruction present or not from the outside. Now local examination. The first local examination is anterior rhinoscopy. So in general, you should look for mucosa of the nose, nasal septum, floor, and lateral wall. This is the protocol you should look for. And in this case, as there is a mass, you cannot find all these things. So local examination on palpation, there is a probe test. Probe test is designed for some interpretation, like whether it is sensitive to touch or not, bleeds on touch or not, consistency, mobility, and margin. This should be determined by the probe test. So modified probe test, if the mass is not visible, you can do a diagnostic nasal endoscopy and do a probe test. Probe should be blunt one, not sharp. Now come to the local examination, is continuing examination of the nasal cavity, posterior rhinoscopy. So what are the structure you should find? Guanal patency, posterior turbinate. In this case there is a blockage of the nasopharynx. Nasopharyngeal mass often found in the posterior rhinoscopy. Whether the ET tube is functioning or not, this should be examined. Now, yes sir.
I will ask one question which may not be very relevant but often asked in the examination. How do you do posterior rhinoscopy? Can anyone tell? I have seen this being asked multiple times in the examination. We do not do it because we all have nasal endoscope. Can anyone answer? Lodjar ki ache? Are this is for learning here. Yes, please.
So we'll be positioning the patient in a sitting position. After that, we'll be using the posterior endoscopy mirror. We can do you can use a Savlon or a hot water to make it as to prevent it from fogging. And after that, we'll tell the patient to open the mouth, and without protruding the tongue, we'll tell the patient to just open the mouth, and we'll put the posterior endoscopy mirror along with the anterior pillar and just try to see the posterior part of the rhinoscopy.
Any instruction on breathing?
The patient will be breathing from the nose only.
Good. I think it is sometimes asked, I have seen multiple times. Huh? Oh, boleni? 6 months. Na bolle, sorry. So yes, you press. And first of all, you have to say any procedure is asked in your examination. You have to say, I will take consent of the patient, and then explain the procedure to the patient. And then I will ask the patient to breathe through the nose, not protrude the tongue, I will gently press the tongue depressor and warm my mirror and then try to look with the posterior
Rhinoscopy
কি
mirror.
বলে জানো? Posterior and mirror. If it is not often asked, but it can be asked.
Now coming to the nasal airway testing. These are the tests that cotton wool test, cold spatula test and cotton test. So what is cotton wool test? So this is cotton wool test and cold spatula test. So local examination. Now cotton test of nasal valve patency. So there is a line known as Cottle's lines. So if any obstruction present in front of the Cottle lines, anterior to the Cottle line, can give rise to a positive interpretation. Means Cottle test positive. And if the any deviation or any mass present just behind the Cottle lines, a negative interpretation is negative Cottle test. So now local examination, this is sinus tenderness, whether it is present or not. Local examination of smell test. Examination of the eye, this is very important, whether proptosis, periorbital swelling present or not, proptosis and epiphora. Palpation, on palpation, there is a orbital tenderness, capitis should be checked. Now again cranial nerve examination, there is optic nerve, cranial nerve 3, 4, 6 should be examined, and ophthalmic branch of the trigeminal nerve.
If I ask you, what are the things that you examine for the eye, particularly in this particular case, unilateral nasal mask with a unilateral sinonasal imaging shows, what he has mentioned, but what are the functions of the eye you want to check? The questions are sometimes asked in this way by the examiner, that you may do this test, but what are you trying to look for? Can anyone tell? Which functions of the eye you want to check? Yes, yes, you. Movement of the eyeball, number 1. Number 2?
Diplopia, vision.
Diplopia is a pathology. I said what functions? In the examination, you should answer what exactly is asked. That is also important for high scoring. Anybody else? One is movement, in ocular movement. Number 2?
Sir, visual field.
Visual field, and
Pupillary
then
light reflex,
visual acuity.
visual acuity.
So primarily you are trying to check 3 functions. Whatever it takes to check all these 3 functions, you will have to check. Because a nasal mask can penetrate to the orbit, press on the orbit, and can give rise to problem of mobility of the orbit. That can lead to pathology, diplopia, then visual acuity problem, and the field defect. So what I am trying to say, in addition to what he is saying, that you should know how to answer in your crossing. Okay?
Now examination of the ear, we look for whether there is any abnormality or any disease present in the ear or not. May commonly present with OME. Examination of oral cavity, this is also important, because in this case there may be, if the patient having some carcinoma inside the maxilla, so patient may present with loosening of the teeth and gum bleeding also. So opacity of the specifically oral hygiene, condition of the teeth, gum, palatal bulge, obliteration of the gingivobuccal sulcus, loosening of the teeth, these are the key points you should search for during your examination. So examination of the oropharynx, examination of the larynx, all are important. Now systemic examination, you should perform all the systemic examination, chest, CVS and GI system, CNS and musculoskeletal system. So now coming to the summary of your case. You should write like a 52-year-old female housewife presented with the right-sided nasal mass for 1.5 years and right-sided occasional right-sided nasal right-sided nasal obstruction and right-sided nasal discharge from the same durations, and which is insidious in onset and intermittent bleeding. So, and on examination, I have found that there is a nasal mass completely obscuring the right nasal cavity, completely blocked by the polypoidal mass with variegated surface presenting at the right nostril. So it does not bleed on to touch, on probing, and oropharynx and palate is NAD, no proptosis, eyeball movement and visual acuity normal, bilateral TM normal, no palpable lymph node. So my provisional diagnosis is a sinonasal mass, probably inverted papilloma. This should be the answer. And you should keep your all differential diagnosis in your mind, so that if your examiner asks any question, why not this is malignant, why not this is infected AC polyp, you should answer your question according to your clinical finding and your clinical examination with history. Okay, thank you, sir.
So if there are any queries before we move on to the differential diagnosis and management part, so our sequence of discussion is, we have discussed the case capsule and how to present the history in the long case, how to take the history, how to come to a summarizing. In summary, you have to always mention the positive points which is relevant to the diagnosis. Whatever is pointing, whatever is coming to your mind before you have investigated. Just from clinical history and examination, whatever comes to your mind with positive finding, that should be summary, very crisp, very short, but it should not include all the points that is in favor of your provisional diagnosis. So after the summary, I think I would invite Dr. Sanjay Ghosh, who will take you through the next step of crossing the next part 1 and part B. Part B is now differential diagnosis and management. And management is workup for achieving a final diagnosis and treatment. So he will take you through the diagnosis discussion, and then minor elaborate discussion will happen on CT scan and on endoscopic surgery for benign disease, endoscopic open surgery for malignant disease. These are the 3 more sections.
Hello. Okay. So in this case, in your exam purpose, whenever you have completed your provisional diagnosis, the most common logical questions is, what are the differential diagnosis? Okay. Sometimes the differential diagnosis should be very close to your clinical findings, because in the examinations there will be no features of CT scan, imaging, MRIs will be available, because only basis of the history portions and the clinical examination portions you have to diagnose it provisionally, and then some differential diagnosis which may be closely associated with the things. Okay. Now, what are the differential diagnosis of these cases we will discuss here. Anyone in the batch, whoever is je batche cholchilo arki, what is the first diagnosis, first differential diagnosis, or what a single diagnosis?
কিরে মাইক্রোফোন না নিয়ে গেলে কি তোরা উঠবি না? লাস্ট বেঞ্চ একদম লাস্ট বেঞ্চ। তুই না?
ও পিছনেও দেখছে। Any nasal polyp. Okay. So what may be the unilateral nasal polyps originating from what are the sinuses?
Sir, inverted papilloma or sir.
Inverted papilloma is not a nasal polyp directly.
Sir, maxillary sinus from like maxillary polyp.
So maxillary polyp originating from the maxillary sinus. Okay. Passage zone. Antroconal polyps, or it may be
Ethmoidal polyp.
ethmoidal polyp. So anterior and posterior group of the ethmoidal sinuses are involved, leading into the ethmoidal polyp. This may also involve the maxillary sinuses, and here is in these pictures there is some certain point of heterogeneities are there, and these may be of, this is not seen in your exam cases, but the examiner will ask you how will you differentiate the ethmoidal polyp, which is most commonly unilateral, is a allergic fungal rhinosinuses, AFRS polyps. So what are the features, CT features of the AFRS polyps, and what are the clinical signs you can see in the diagnostic nasal endoscopy, so that you can differentiate it from the antroconal polyp and the AFRS.
AFRS like double density or railroad tracks, double density, sir.
Double density sign in the imaging process, and the clinical examinations.
Clinic like thick purulent, cheesy kind of purulent discharge.
Purulent?
No, sorry,
not
thick,
purulent.
Thick cheesy discharge.
Cheesy concretions are present over there. They are like calcium deposits like things. These concretions are there. Okay. Any over there, ma'am? What are the CT findings, features? are between the antroconal polyps and the AFRS. But how can you differentiate a antroconal polyps with a AFRS? I can differentiate with a CT scan.
In CT, in fungal polyp, we may see double density sign.
AFRS, okay.
AFRS.
Oh, it may be a single fungal granuloma. This is other things. This is other clinical scenario. But AFRS, the double density, and how does, and any other clinical, any other CT findings other than the double density signs? Passage.
Sir, it will be heterogeneous.
That is the double density sign. Oh, yes, told you. Any bone destruction, bone remodeling, new bone
erosion.
generations are there or not, it can be seen in the CT findings. Okay. And another passage on any other differential diagnosis than the AC polyp and the AFRS?
Sir, if AC polyp homogeneous.
No. AC polyp and AFRS is over. Any other differential diagnosis in this case?
It is all in the screen. You can pick up anyone.
So it is,
And
there is a history.
based on clinical finding and history, you have to
Based
now
on the
tell.
clinical findings in history.
Because the
15 years
investigation
old
will come later.
female patient, there is a sometimes history of bleeding is there from the left side. Sometimes bleeding from the left.
JNA.
JNA in a not female is very not common. JNA is common in male because this is a very common question of JNA. But before that, a JNA, Passage John. He has already mentioned over here.
Inverted papilloma.
Inverted papilloma, very good. So inverted papilloma may be there. So there is a high vascularity is there. Now, Passage John, what is the pathology or pathophysiology of the inverted papilloma? Because these are the common questions examiner will ask you in your viva table. What is the pathophysiology of the inverted papilloma? How will you diagnose the inverted papilloma? It is very difficult to diagnose it by only through imaging.
So for diagnosing the inverted papilloma, we have to do the diagnostic nasal endoscopy examination and multiple deep-seated biopsy have to be taken.
Very good. So what is the biopsy HP findings features of the inverted papilloma?
Sir, papillary
Characteristics.
Why is it called inverted?
Why it is
That
called
is what
inverted?
he is asking. Anyone? Please answer.
এখানে বলতে
এই নিয়ে সামনে মাঝখানের দিকে দাও তো
বল জোরে বল
the middle
endophytic
row is
growth
not
pattern.
answering at all.
Say endophytic growth pattern, there will be thickening of transitional epithelium and that intact basement membrane, and most likely there will be no stromal invasion.
Okay.
So it's a pathological diagnosis.
Pathological diagnosis. So what is the commonest, how can you manage the inverted papilloma patient? These are the another common questions if the examiner will go into the inverted papilloma.
So surgery.
Surgery. So what is surgery will do?
So will go for lateral and
Passage John, hath tule jaओ.
Medial maxillectomy.
Very good. The medial maxillectomy. Now medial maxillectomy may be a open approach is there, medial maxillectomy, or endoscopic approach. So here is another common question is what is the endoscopic approach of medial maxillectomy? What is the Denker's approach? You?
Denker's endoscopic approach.
So what is the major steps Denker's approach?
Sir, we have.
It is the same as the medial maxillectomy general approach. And how will you do the Denker's approach?
Sir, we have to expose the anterolateral wall of the maxilla.
Very good.
Up to
By?
the,
How? Endoscopically how it is possible? Because
from the pyriform aperture.
From the pyriform aperture. So give an incision over the lateral wall of the nasal cavity, elevate the mucoperiosteal flap over there, expose the frontal process of the maxilla, then remove it, then go into the anterior. What is Denker's line?
Sir, inferior orbital foramen up to the.
So it is parallel to the inferior. You cannot cross over the lateral to the inferior orbital line. Okay. And posteriorly, if the disease is already is by a diagnostic endoscopy and biopsy, it is proven that it is a case of inverted papilloma. Then what structure you can preserve over there? If goes posteriorly, I will not remove the whole block of the medial portion of the maxilla. So I will not do a whole medial maxillectomy. So what important structure you can preserve if it is not malignancy? This one. This ma'am. Passage John. এইখানটা একদম সাইলেন্ট আছে, এইখানে এখানে
স্যার কোশ্চেনটা একবার রিপিট করবেন।
What important structure you can preserve during medial maxillectomy if it is proven that it is a case of inverted papilloma, not a malignancy? Sometimes there are different indications of the medial maxillectomy is if it is a locally malignant growth or very slow malignancy growth is there, or it is a repeated recurrence of the functional endoscopic sinus surgery, recurrence of the diseases, then what important structures you can preserve over there?
I think nasolacrimal duct.
Very good, the nasolacrimal duct. These are the subtle questions examiner will ask you to see whether you have understanding the whole concept.
Oh,
okay.
one more.
Yes.
On MRI, we can also find cerebriform pattern to diagnose the IP.
Very good.
Sorry to interrupt. We have with us Dr. Ritu Seth, our AY observer from AY from Mumbai. She is also the editorial board member of iJones. Welcome, madam. Please go on.
So another benign conditions may be JNA, but it is not accepted here because it is a female patient. Juvenile nasopharyngeal angioedema is a different case. If it is a male, it will come into scenario, and there are so many good questions in the Viva table for JNA. Okay. So one of the one is my favorite questions in the JNA. During the treatment procedures of the JNA, there is an endoscopy, and there are different approaches of the JNA, but we can do a preoperative embolization, right? So tell me just what are the pros of the preoperative embolization, and what are the cons of this embolization?
So preoperative embolization will decrease the blood flow make the vascularity will decrease, so the operating procedure becomes easier.
Okay.
But since the vascularity is decreased, delineation of the tumor tissues while operating becomes difficult.
Okay.
So there may be a lot of tissues that might be left behind while we are operating.
Very good. So this is the answers you can give, and there are some malignant tumors may be also there, which is the commonest is the squamous cell carcinoma, another is the adenocarcinoma may be there, and fungal ganglioma. Now how can you differentiate the benign how can you differentiate the benign and the malignant tumor clinically?
Rapidly growing tumors
Okay.
can be malignant. Bleeding might be present in malignant tumors.
Okay.
Pain can be a symptom in case of malignant tumors.
Okay. Any other?
Bony destruction and
Bony destruction you cannot see clinically so much. So the other areas are involved, whether it is limited to the nasal cavity and the paranasal sinus, or whether it is extended, you can see this clinically. Okay, the eye signs may be positive. Any neck nodes are there? Maybe the পেছনে যান, পরের দিন। What is the commonest neck node? What is the sentinel nodes for the maxillary CA?
The anterior half will drain into the submental nodes, and the posteriorly it will go into the retropharyngeal lymph node and to the level 2 lymph node.
Retropharyngeal nodes are commonly seen, so the sentinel nodes you can see in case of the maxillary CA. You can so you may differentiate the benign and the maxillary pattern. So I will ask another question. So sit down. How can you go with this differential diagnosis to the management? So it is the first thing is the diagnostic nasal endoscopy, DNE. So these are the common questions in the DNE. What are the passes of DNE?
So there are mainly 3 passes.
What are these passes?
Sir, first pass is up along the guana to see the along the floor to see the guana.
Okay.
Second pass is medial to the medial.
Not medial, lateral to the
lateral to the middle.
Middle terminal.
Middle
that is
terminal.
Between the middle terminal and inferior terminal. You want to go into the middle meatus. Okay. Then
the third pass is the lateral to medial to the middle turbinate.
So you want to go over there.
Go over the this is the
known as
sphenoethmoidal
superior meatus or the sphenoethmoidal recess. So it is the DNE portions, and you have to do you have to do a biopsy if there is any doubt in your mind, because the disease is so much before the biopsy or DNA, obviously we have done the CT scan or imaging. So with these CT scans, in these features, there is a heterogeneity is there, I need to do a biopsy. So where from you will take the biopsy?
Preferably from a representative area like
Like?
deep.
So if the mass is here like the anterior nasal mass, that is the anterior nasal cavity, the through is exposing through the nares, then how will you do the biopsy? How will you where from the biopsy will be taken? The mass is coming from the nares.
Sir, we will take both superficial and deep biopsy.
Superficial biopsy we will not take, we may remove the superficial mass and take the deep biopsy beyond there. Okay. So patient না এদিকে এদিকে ওদিকে হয়নি ইউ এই সামনে একদম সামনে So every cases we will take the biopsy, or there are some cases we may not intervene into the biopsy.
If it is vascular mass, then we should not take the biopsy.
If it is
vascular origin, then we should refrain from taking the biopsy.
So if there is it is a vascularity is very high, so we may think it is a JNA, then we cannot take the biopsy, as in case of the JNA the bleeding will be very higher. So how can you understand it is from the JNA? What is the basic clinical features in the CT scan? You can diagnose it is a JNA and there is a bleeding mass, there is a angry looking mass, and in a specific sign is present in the CT scan. So I will not take a biopsy. What is the specific sign in the CT scan for the JNA?
Holman Miller sign will be there. Holman Miller sign will be there.
শুনতে পাচ্ছি না পাশের জন
Any vascular involvement?
Vascularity is higher. Okay. So any specific sign which will guide it, it may be a JNA.
The Holman-Miller sign
Holman-Miller sign sometimes present, sometimes may not be present, because if it goes into the infratemporal fossa, pterygomaxillary fossa, then only, but which is the initial
the mass will be homogeneous.
Okay, but ওখানে হাত তুলে যাও.
Sir, if we do the contrast enhanced CT scan, we see the contrast is taking.
The vascularity is higher. Okay, I understand. Very good. The widening of the pterygoid plate is the first signs we will have seen in case of a CT scan. Then the mass goes into the pterygomaxillary. There are different lots of questions examiner will ask you from there. What is the pterygomaxillary fissure, pterygoparatine fossa, infratemporal fossa, boundary, the contents, everything you need to know about there. Okay, and I can any other questions? So in case of malignancy, sometimes the biopsy, the result, the HP is not very much positive to the pathology, and they may ask you for also immunohistochemistry for a final diagnosis. So if a mass is, my last question is, if a mass is present within the maxillary sinus in a CT scan and you cannot see the mass through the nasal cavity, then how can you take the biopsy? And if it is a malignancy, you are suspecting this may be a chance of malignancy, so how can you take the biopsy from the maxillary sinus?
So, Caldwell-Luck approach.
Will you do the Caldwell-Luck approach? পেছনের জন এখানে বলছে করব না, Caldwell-Luck approach করব না, তাহলে কি অ্যাপ্রোচে করব এখানে? হ্যাঁ middle ম্যাথ. Why will not do the Caldwell-Luck approach? Very good. He is saying the mass may come out of the anteriorly and there may be the upstaging of the malignancy, because there is a beautiful result may come in case of the maxillary CA if the maxillary CA carcinoma is within the box. There are the difference in the prognosis in case of the maxillary carcinoma if it is within the box or it goes out of the box. So if it is within the box, frontal maxillectomy gives a very beautiful prognosis, a very beautiful result. Okay, my topic is over here. I will transfer it to Dr. Moinak for the CT scan portions of different clinical cases. Okay.
All the relevant features, relevant points that is discussed. Wonderful discussion we have had since morning. Over to Dr. Moinak Datta from AIMS Kalyani. He is going to take us through the basics of how to read a CT scan and how to correlate your CT with the case history. These are the 2 points he will.
Okay, good afternoon. Thanks to Dr. Sanjay because he has actually covered a lot of details of scan. So it will save little bit of time and it will be very fast basically because we are running short of time. Now see, we will just touch over the very basics of CT scan which you will be getting in your exam. Not go to very details because you will get the CT scan as a part of the long case or as a separate table maybe or in the viva. Generally what happens that we don't get, you are not given a CT scan while you are giving a viva, okay, just your face to face 1:1 interaction, the patient may or may not be there. But so we have to stick to the basics. But before that I will request you not to forget about the very basic definitions of the normal CT scan. Many people actually just forget and go and read the CT scan starting from the pathologies actually. But examiner may ask you any of these details, so I have to, I will not go into details, you all know, it is there in the Bradu, it is there in the first chapter of the EPOS guidelines, just go through them, okay, but these are very, very important about the normalcy and the variations. So, we have to concentrate ourselves into these following disease: chronic rhinosinusitis with or without nasal polyp, AFRS, AC polyp, JNA and any sinonasal mass which may be benign, which may be intermediate group or which may be a malignancy. The inverted papilloma belongs to the intermediate group and most of these things actually have been discussed by Dr. Sanjay, so I am not will go into detail, but remember just at a glance when you get a unilateral mass, so it may be a case of any of these these are the things of the unilateral mass you can get. Generally CRS is actually bilateral. So just at a single glance you can see that which can be the differential diagnosis of the given CT scan. Now we will just go through these 3 basic questions. Why do we actually do the CT scan? Where we can advise an adjuvant MRI and how to read a CT scan, which is most important. Now we do CT scan because obviously we need to know the extent of the lesion, the structures involved in the nasal cavity and the sinuses by the lesion, the bony architecture changes, maybe erosion, maybe remodeling, whatever it is. An idea about the texture, how is the mass looking like, whether it is solid, whether it is have some air bubbles in it or whether it is a mucosal thickening simply. To plan the treatment, that is a decision making is a very, very important point regarding the imaging and obviously for follow-ups, not only for diagnosis but also for follow-up. So, suppose the erosion versus remodeling, because I am not going to the disease detail, just see, look at this, it is simply a chronic rhinosinusitis with nasal polyp. Here you can see because of a huge bulk of the disease, there is a thinning of the maxillary sinus wall compared to the right side. This is because of pressure. Okay, but the same thing remodeling occurs in case of an AFRS. Here you can see the soft tissue window and a bone window where there is a reactive osteogenesis. So, a particular disease causing both thinning as well as a thickening of the sinus wall. So, you have to be very careful regarding reading these scans. These are the remodeling, examples of remodeling. And here you can see a frank erosion where a malignancy obviously you can know, which is eroding the floor of the maxillary sinus and coming into the oral cavity. Now you can see the planning and decision making, this is very important. See, this is a case of a CRS with the nasal polyp. Now the patient came to you in this way. Now you are giving some maximal medical management or an appropriate medical management as the terminology is used in EPOS now. Now you are planning certain treatment here. Now after MMT, this is a reduction of the volume of the disease. So obviously your thinking of the treatment will also be accordingly. So you are planning to do a bilateral face here, but now you are restricted to only a simple left-sided MMA. So in this way, the CT scan will guide you how we should approach or decide on the treatment management of a given disease. The same thing, this is a patient which initially came to you. Here you can comprehend that this patient may improve on just giving a medical management. We may not even require a surgery. So this is how a CT scan may guide you regarding the management or decision making. Now when we will go or add MRI, okay, so MRI can be added as an add-on or as an exclusive sole imaging to replace CT scan. How and when? Now MRI will be added as an add-on when you are suspecting the lesion to be involving some other adjacent vital structures like the sinus, the orbit or into the intracranial compartment. or you are suspecting a skull base breach where there is a herniation of the meninges with or without a brain content. So, meningoencephalocele. In those cases, you can add MRI as an add-on along with CT scan. Few examples we can see here. You can see differential consistency. See, here is a CT scan of this particular patient, axial cuts. There is some radio opacity here in the posterior ethmoid and sphenoethmoidal recess, and also into the sphenoid sinus on the left side. The same patient underwent an MRI where you can see these two lesions are completely different, which we could not understand through the CT scan. So, here you can see it is basically a collection or some mucosal thickening, but there is a definite fungal component into the sphenoid sinus, which could not be understood in the CT scan. So, this is how MRI will aid you in determining the exact pathology of the lesion and its extent of the lesion. Similarly, in the CT scan here you can see a mass lesion may be there, but how it is what is the extent of the mass lesion, how it is destroying the or actually involving the confines of the sinus could not be well appreciated unless you do an MRI here. You can see that it is eroded the medial wall, it is eroded the posterior wall of the maxillary sinus, and it is quite a heterogeneous lesion. It is not a homogeneous lesion as we can see in the CT scan. This is the intracranial extension. I am not going into details, but we will be very fast. Intraorbital extension you can see here. The question was asked how it can change the orbital function. I will to add what you told into the epiphora. Please add this thing, orbital movement, decrease orbital movement, vision, and add to that epiphora. Epiphora will be there because of obstruction of the nasolacrimal duct drainage. Similarly, here you can see a breakage in the or a defect in the cribriform plate on the left side. This may or may not contain the brain matter. Okay, so to complement this, whether to know whether the brain matter is there or not, and thereby to design your surgery, you have to do a MRI. In this case, you can see the brain matter is hanging down into the nasal cavity, suggesting to be a meningoencephalocele. And when MRI is act as a sole imaging, okay, only MRI can substitute a CT scan. Obviously, as I told you here, you can see a huge meningoencephalocele just hanging into the nasal cavity on the right side, and there is a collection in the maxillary sinus, secondary sinusitis. These two lesions are different, and this diagnosis is also only exclusively diagnosed with the help of an MRI. Here you can supplement or rather replace CT scan with only an MRI. Patient coming to you with a nasal mass suspecting it to be a CSF leak, maybe it is a child, when 3 or 4-year-old, obviously you just go off with the CT scan and do advise an MRI or MR cisterno, whatever it is. Similarly, the JNA here you can see this is a MRI basically. Ideally, CT with contrast is the initial treatment we advise for a JNA, but you can advise an MRI if you like to, because that can also give the same information involving the nature of the lesion as well as extent of the lesion and bone erosion also. Here also you can see a mucocele or a mucopyocele. Here also you can best to go with a MRI first to avoid any double or extra investigation. Because you can see in the CT scan, it is not giving a very good idea regarding the content of the mucocele. But here you can see, you can differentiate the fluid content with the solid content, WBC content or pus content. Okay, that is different, understood only with the help of an MRI. Now, let us ask you some questions. How to read the CT scan? This is actually you need to know each and every point is important. You should not miss any of the points given here. How to read a CT scan? You are given a CT scan, how will you read it? What are the points you should cover? Anyone? Now start. You can see and tell, no problem, all are given here. So, first of all the cuts. Initially you should look for the scout film if it is there, not always it is there, and there are the different cuts, axial cut, parasagittal and the coronal, of which the axial is the primary cut because it is the position of the patient on which the cut is being taken. All other cuts are reconstructions, parasagittal and coronal, they are all reconstructive cuts. Then come to the window, soft tissue and bone window. Okay, so what is soft tissue and what is bone window, any idea? These may or may not be asked in your exam, but still you should, since we are doing a small class on the CT scan, who will, we should know the basics about these windows. Okay, very basic, only 1 or 2 lines.
For a soft tissue window 500 HU units, for a bone window around 2000 HU units.
But there is nothing specific for that. Yeah. Okay, there are windows. Window means range. Okay, so window means range and So let's go into this detail. We'll come back to that these points later here. So we call it a windowing or the graying level mapping or gray level mapping. Here we can see this in this particular imaging you can see this called the window width. Okay, this is nothing but the Hounsfield unit. We call it CT number also. So this is the CT number or the Hounsfield unit range. Okay. Now this will more wide the window. This will incorporate different types of tissues, starting from bone, starting from blood vessels, starting from different types of soft tissue, starting from even the areolar tissues also. The more wide the window, the more details of the tissues or heterogeneity of the tissues will come in. The more we narrow, okay, then we can narrow according to the need. We want to see the soft tissue, we want to see the bone, we want to see the bone cortical, we want to see the bone temporal bone. So different types of bones are also there. Accordingly, we can narrow down on that particular window and pinpoint our area of interest. For example, here you can see this. Suppose we are going to see a cortical bone. So we will go approximately in this particular area, 1500 to 2000 Hounsfield unit. It's not a range, it's not a definite figure, remember. But temporal bone, since it is a very delicate and very intricate bone to understand and study, they have a wide range of more or less 1500 to 4000. Okay. So this is how the window is actually determined, bone window and soft tissue window. But general for take home message is this one, 350 to 400 Hounsfield unit is generally soft tissue structure and 1500 to 2000 is generally the bone, generally. Okay. Now there is another thing called the window level brightness. As we adjust the brightness in our TV and etc. The same thing here. Look at this thing is a bone window here, but see this is a very low brightness is low here. Okay, and this particular case the brightness is comparatively high. This is not much of use to understand the windows because they are already in the bone window. You are just increasing or adjusting the brightness. Ideally for the temporal bone the brightness is 700 units. So this PowerPoint will be with you. You can go back and see. I am just going a little bit fast to make up with the time. Now windows and from how, then third point is the direction of reading. You can go anterior to posterior, you can go from medial to lateral, you can go from superior to inferior depending upon the cuts involved. Okay. Next is look for the normal structures first. This is very important. Don't jump into the pathology. First try to see the normal structure. Keep it in your mind, you do not have to tell it, but then you will go ahead with the pathology involving the different structures in the nose and PNS. Next is assess a lesion in terms of extent, radiodensity, adjacency to the vital structure. This we have covered, orbit, then the brain, whatever it is, or extra nose activity involvement like the pterygoparietal fossa, infratemporal fossa, etc. And use these terms, radio density, etc. for CT scan and intensity for the MRI. These are very common slip of tongue actually, but keep this in mind when I am describing imaging MRI or CT scan, you have to mention these particular adjectives basically. Laterality, very important. We always miss this thing, right or left, okay, or bilateral. Be very careful on this. Contrast enhanced or plain, okay. And look for the condition of the bone. This I have already discussed, breach or remodeling or erosion, etc. So these are the things we have to cover while reading a CT scan. Whatever CT scan is given to you, including MRI also, but for you CT scan, these are the points we have to cover. Now I just go with one example. 2 minutes time. So 2 examples. So I will not go into further details. Example. Okay. Now someone tell me or describe this CT scan along those points which I have discussed. Mic kotha? Where is the mic? You start off. Just describe it. You know the diagonal. I know. Already this has been discussed. The same patient, the same cuts in 2 different windows.
This is the axial cut of paranasal sinuses. First 3 pictures are soft tissue bone window and second 3 pictures are soft tissue window. There in the first picture we can see there is lateral deviation of nasal septum, and on the second picture there is a right sided unilateral sinonasal mass involving
right sided or which side?
Sorry, it's left sided.
Left, so laterality very important, okay.
Involving nasal maxillary sinus and nasal septum also.
Septum, no, the nasal cavity and the left maxillary sinus. Okay.
Yes, with the mucosal thickening of the opposite right sided. Mucosal thickening on the.
Okay, you use this pointer and show me. In the tell me the lower row.
Lower row is a soft tissue window. There are peri-orbitas are, I think, intact. There is no orbital involvement.
What are you seeing? Negative points later. There is a mass lesion involving the left maxillary sinus and nasal cavity. Okay.
This is a heterogeneous
mass lesion. Then showing
there
what?
is no particular bone destruction I can comment on, but I think there are.
But the definite bone thinning in the posterior wall of the maxillary sinus.
Posterior of the this part.
Yes. Then.
Yes. And
what is the content of the lesion? You can see.
What is the nature of opacity?
This expansile, heterogeneous, and.
What term should you use? You are missing there. It is what is the diagnosis?
This is
A for S. Then what point you should describe to them to state this lesion on the left maxillary sinus?
Hyperintense.
Okay, hyperintense.
Double dense.
But this is an intense. Don't use the term intensity here. It's a CT scan.
Okay.
So these points should come into you. No usage of the terms intensity. Double density bone, no? That is the point.
Whenever I am just interrupting, whenever you are asked to read a CT scan, you should tell the points in favor of the diagnosis that you are going to pronounce. So this is AFRS. তাই বলছো তো? হ্যাঁ. So in AFRS, you know what are the radiological criteria, whether it matches or not, and then you diagnose. আরেকটা কি দেখাবে?
আরেকটা দেখিয়ে দিই last.
Volunteer, be ready.
Okay, it's this one. Someone কে বলবে? Describe. বলো বলো বলো। Just describe.
ওই বেঞ্চকে দিয়ে দাও, যে বলবে বলবে।
So this is a contrast enhanced CT scan in the axial section showing
the upper row is the soft tissue window, the lower
upper row is
window.
the soft tissue window and the lower row is the bony cut window showing heterogeneous mass occupying the left sinonasal left nasal cavity and the left maxillary sinus, causing deviation of the septum to the right,
erosion of the
anterior wall of the maxilla, and in the bony cut I can appreciate that it is also eroding the posterolateral wall of the maxilla and extending into the
it's occupying the entire nasal cavity, almost
up to the choana. Up to the choana.
So what is my provisional diagnosis here, seeing the CT scan?
Most likely it is a sinonasal malignancy, most likely CA maxilla.
Okay.
Thank you, Manak. So we will in the next 10 minutes we will take you through the basic steps of FES. What are the common questions asked? Because you might get a case of enterochoanal polyp or a ethmoidal polyp, as we have discussed. So first question that is usually asked, can anyone tell me what are the steps of uncinectomy? Please, fast. No volunteers, then I'll have to just go in a didactic nature. Thank you.
Sir, first at the junction of vertical and horizontal part of uncinate, we give a cut with backbiting forceps, and then sir with a ballpoint probe, the vertical portion is pulled forwards, and then with the help of a Blakeslee forceps we can remove the vertical part, and then we can also medialize the horizontal part.
Perfect.
Then sir we can remove the horizontal part also.
Thank you. So first delineate the junction of the vertical and horizontal. This is vertical, this is horizontal. This delineate this part, make a person's window as he said, and then proceed upwards and downwards. This is a video to show there is a polyp coming out through the middle meatus on the left nasal cavity, again palpating and delineating the junction of the vertical and horizontal part, and then introducing a backbiter. I think you will see in a minute that we are seeing the junction of the uncinate with the lateral nasal wall, and this is the junction of the vertical and the lateral wall. Go with the Blakeslee wild forceps with a closed blade as he has said, and then pull and retract and cut. Take 1 or 2 or 3 bites depending on the size, and here you can actually see it is opening into the maxillary ostium, maxillary antrum. You can see the polyp being present here. The next step is removing the upper part of the uncinate process, vertical part of the uncinate process. If you are going to do the whole thing up to the frontal sinus removal, and this is the horizontal part of the uncinate process, which you can either remove with a Blakeslee forceps or with a, so the uncinate bone, as you can see, is being, and this is the horizontal part, because many a times the polyps are not there, so you have to look for the natural ostium, and therefore you have to do the horizontal part, and as you know, the horizontal part or covers the maxillary sinus bulk, and so this is the complete uncinectomy, and you can see this is what. Now, what are the dispositions of various ostium? Generally, it is asked, what is natural, what is accessory? Anyone? Quickly. Please volunteer, please, we don't have time. Yeta kya kar kache ache? Pass your thing, please.
Sir, the natural ostium will be present in a 3D plane, obliquely.
Perfect.
The axillary ostium will be present in a 2D plane and will be completely circular in nature and slightly smaller.
Perfect. So, as you can see, this is right nasal cavity. Uncinectomy has been partly done. This is the horizontal, vertical part of the uncinate still left behind. You can see this is a hollow 3D like structure, which is present in the anterior part, and that is in the third part of the hiatus semilunaris. First 1, 2, 3, 4. Third part, which is related to the Parsons window area, and this is a 3D structure, and this is a accessory ostium, because this may be diagnosed even on diagnostic nasal endoscopy. This is nothing but a slit which is oval or circular on a bony lateral nasal wall where there is no bone, which is fontanelle, and that's why these are the two differences of how you understand which is natural, which is lateral, which is accessory. This is accessory, this is a deep, you can see, and both are leading into the antrum, as you can see here. Then what are the complications of uncinectomy? Anyone? Just pass it on to the next table. Each table one answer for this session. Complications of uncinectomy, I have delineated already, anterior, posterior, inferior, superior.
Complications at the uncinate process, upper part can have various different attachments. So, if we avulse the upper part of the uncinate process and it is attached to the cribriform plate, there can be fracture and CSF leak. And anteriorly and middle meatal antrostomister, if we go too much anterior, then there will be the nasolacrimal duct. So, we can injure the nasolacrimal duct.
Perfect. Posteriorly?
Sir, posterior sphenopalatine artery injury.
Absolutely. If you go too much posteriorly, you will encounter the sphenopalatine foramen, and you can bite onto the artery with a torrential hemorrhage. And
superiorly orbit injury?
Superiorly, she has not mentioned orbit.
Orbit.
Yes, uncinate can be attached to the skull base. It is attached. But the orbit is here. This is the maxillary sino where there is a cyst and a polyp, and this is the superior wall. This is the roof of the floor of the orbit, and this is the posterior wall. You can go into the sphenopalatine foramen, and this is where you can come into the nasolacrimal duct, and inferiorly you can damage the inferior turbinate. That's all. So I am putting this picture so that you can remember this picture when you answer your questions. Very easy. 4 quadrant, what damages you can cause. Now, what do you do during FAST when there are accessory ostia? Next table, quickly.
We can complete the ostium with join the ostium.
Got your answer. So you basically join. Why do you need to join? Next table. We'll just rotate the mic. See, we have joined these two here and made one opening.
So for better exposure and ventilation.
Yes, because there will be recirculation of mucus and that will work, that will function as a nidus of infection for future. What are the steps of anterior and posterior ethmoidectomy? Next table. These are the questions that are asked in the Viva or related to your case. How do you do anterior ethmoidectomy?
Sir, in anterior ethmoidectomy, first we do the bulla ethmoid. First we expose the bulla ethmoidalis with a curette. We remove the mucosa of the bulla ethmoidalis, and after then we enter into the bone and clear it wholly.
This is left nasal cavity, as you have said. This is the bulla ethmoidalis. This is MMA. This is middle turbinate, left nasal cavity, and we are just puncturing the bulla. We are removing, going to the bulla is the largest anterior ethmoidal cell. We are going to remove the cell after dissection, and until we have seen the ground lamella, which is the end of anterior ethmoidectomy, because that starts the boundary of posterior ethmoidectomy. This is a better picture where you will see the ground lamella very clear, though we are using a micro debrider here, but this is another way of doing it. You can go behind the bulla if there is a retrobullar recess and do a retrograde bullectomy or bulla removal, and then therefore there is no chance that inadvertently you will enter the posterior ethmoid, because as you can see the bullar shell has been removed, and this is the middle turbinate, and you can see this is the ground lamella very clearly, and that is your boundary between the anterior posterior. Now we will discuss about what are the complications of ethmoidectomy in general. Next table. Kya bolbe, please? Someone? If you pass, don't please carry on.
There can be chances of bleeding because of the presence of anterior ethmoid artery, and as it is just 1 centimeter below the middle axilla of the middle turbinate.
Perfect, very good.
And then any injury to the ethmoid, upper part of the ethmoid can cause injury to the skull base, which can cause CSF leak also. And if you go more laterally, then it may injure to the orbit area also.
So you must remember the anatomy when you think of complications, like I showed in for uncinectomy or MMA. This is the left nasal cavity, as you can see. Anterior ethmoidectomy has been done, and you can see this is the frontal recess area, and this is the anterior ethmoidal artery. So anterior ethmoidal artery will cross between from orbit to the cranium, and it will just pass the nasal cavity, which may or may not be. How do you identify the anterior ethmoidal artery on CT scan?
There's a nipple sign. Nipple
sign. So you should see if there is a bony covering is absent, then you have to be more careful in this case. And obviously CSF leak, because what forms the roof of the ethmoid? It's the cribriform plate. Medial and lateral lamella, most of the time it is lateral lamella. So lateral lamella leak is more common for uncinectomy if you go superiorly. If you go laterally, you are going to the orbit, causing orbital complications like penetration, and there is a long list of orbital complication and injury to the artery. What are the various approaches to the sphenoid sinus? We are going sinus by sinus. What are the approach? Next table, just rotate the mic, please.
So the approaches to sphenoid sinus are the lateral approach, intermediate, and the medial approach.
Okay.
In the lateral approach, there is an imaginary line over the roof of the maxillary antrum, which goes behind, and below the line it will be the sphenoid sinus, and above that would be the posterior ethmoid. Another is the medial approach, where we go medial to the middle turbinate to the sphenoethmoidal recess, and intermediate approach we go to the middle turbinate.
So this is ethmoidectomy performed. You are, as she is saying, you are going, following the anatomy and going posterior inferior to the posterior ethmoidectomy cavity to enter the sphenoid sinus. This is the lateral approach. The median approach is finding the going to the sphenoethmoidal recess and finding the natural ostium of the sinus and widening it. That is the median approach. Because of shortage of time, I cannot show you more than this. And this is intermediate. You go, this is the sphenoethmoidal recess. You remove the polyp. Polyp may not be here all the time. So you have to come from this side. This is the medial side. This is the lateral. This is the septum. And from the ethmoidectomy cavity, this is the middle turbinate, and through the middle turbinate you make a slit and go again into the sphenoethmoidal recess to identify the natural ostium, as you would see here, and from there you would go into the sphenoid sinus. What are the structures that may be injured? This picture is absolutely, I have given this picture because there is shortage of time. But can someone delineate what injuries can be caused during sphenoidotomy?
The main injuries will be, the optic nerve injury will be present, sir. Close to the sphenoid sinus. Close to the sphenoid sinus there is a optic nerve and carotid artery, internal carotid artery, and there are also salla turcica which may be involvement.
So primarily it's the optic nerve and the carotid artery. Now, what is Onodi cell? I will not ask question now because bell is ringing behind my ear. So Onodi cell is a posterolateral extension of ethmoidal cell beyond the anterior face of sphenoidal sinus. So it is going posterolaterally, and therefore if you see this axial scan, you can see ethmoid sinus ideally should stop here, which is away from the orbit. It is pneumatized beyond this, and if you look at this coronal scan, if you see any vertical cell over the sphenoid sinus, as you begin to see the sphenoid sinus from anterior to posterior, those are Onodi cell. What happens? The optic nerve can be directly involved there, and therefore, and this is the anatomy of the sphenoid sinus, left side optic nerve, lateral OCR, carotid optic recess. So if you have a Onodi cell, actually Onodi cell will be here. So you can go into the Onodi cell thinking that you are in the ethmoid and you are safe, but you are still going to damage the optic nerve, as you can see here in the left side image. Frontal recess 1 point. What are the determinants? I think I am not going to ask any more question. This is the question asked. Agar-Nazi uncinate process bulla, how much bulla is pneumatized, what is the attachment of uncinate process, and how many layers and how wide is the Agar-Nazi pneumatization will dictate how narrow or how open the frontal recess will be. And in addition, various types of ethmoidal cell which you need to know the classification, the international classification, the Kuhn's classification, all these things will be asked in the exam, and that will govern how the frontal recess will drain and which part of the middle meatus the frontal recess will drain. Okay, you need to read that, no time for discussion. And this is again, I think, frontal recess surgery. What are the complications? Ideally, all of us should see this kind of an image when we do a frontal sinus surgery, making sure that we have opened everything. And anterior ethmoidal artery injury, as we have already discussed, orbital penetration because orbital cells are there in the frontal recess. Skull base injury can also happen because anterior ethmoidal artery area is the skull base if you injure, and obviously incomplete clearance. So I would now quickly ask Dr. Devabrata Das to come and take us through maxillectomy.
So, so far we have discussed till the endoscopic surgical aspects. So, you have heard about the all endoscopic approaches. So, my area of discussion will be the open surgical methods for the mainly the neoplastic lesions, namely the particular case is a case of inverted papilloma. So, I would like to start from the last branch, from the left last, exactly. Rajiv, tor samne hai. Oat. So, suppose this case, inverted papilloma, confined into the left maxillary sinus with having a polypoid component in the, or a component in the nose. You have, the case has been biopsy proven. So, what surgery will you do? You get my question or not? So, you have a case of biopsy proven inverted papilloma involving the left sided maxillary sinus. Now, how will you approach it surgically? Jodi na parish passer jon ke pass kore de? Pass it. So, what will be your surgical approach? Sir, open approach.
Sir, face or Denkers?
No, we have discussed the endoscopic approach. I am talking about the open approach. If you had to open it, what approach will you go for?
Lateral rhinotomy.
Exactly. So, it will be the lateral rhinotomy approach. And the incision used for the lateral rhinotomy is the? It's the classical Moore's incision. So, it's the classical Moore's incision through which we usually do the lateral rhinotomy, and the rest is medial maxillectomy. So, pass on the mic to the next person. So, what do you mean by medial maxillectomy?
Removal of the medial and inferior plate of the maxilla.
and removal, exactly, rightly said, to removal of the inferior and the medial wall of the maxilla, preserving the, what are the structures you need to preserve?
Posterior part is preserved.
Preserving the orbital floor, number one, and the
Nasolacrimal duct.
and the nasolacrimal sac,
Nasolacrimal duct.
of the nasolacrimal, I mean the lacrimal sac and the nasolacrimal duct. So this is how you should go for a medial maxillectomy. So next to the mic. So we all know that the inverted papilloma is these are the frequently asked questions in the examination. So you all know that the medial maxillectomy, the inverted papilloma is a notorious entity for the recurrence. So what are the steps we will do in surgery to prevent the recurrence? As far you have identified that the tumor has its epicenter on the lateral wall of the maxilla. So what additional maneuver will you do to prevent the recurrence of inverted papilloma? Anybody want to? Pastor John mic pass koro de. So you need to drill out that epicenter so that the chances of recurrence will be less. So this is about, in a nutshell, about the medial maxillectomy. Then for cases of types of so there are several types of maxillectomy, you know. So suprastructure maxillectomy, infrastructure maxillectomy, depending on the location. Drilling the epicenter. So to discuss regarding the partial maxillectomy. So after endoscopic lateral linotomy and medial maxillectomy, we will discuss on the partial maxillectomy. So in those cases, those are the cases where we need not have to sacrifice the entire maxilla because it has a function to do, because it has a component in the palate that serves us in while we taking food. So the partial maxillectomy is divided as suprastructure and infrastructure. So what is the line that has divided the maxilla into suprastructure and maxilla? Ke bolbi?
On-grain lines.
Tell me, what is on-grain's line?
Sir, it passes from the medial canthus of the eye to the angle of the mandible. Above the structure, above the line
right.
is the suprastructure. So, below this is the
excellent. So pass my mic to the next one. So can you can you prognosticate the tumor by its location, that whether if the tumor is situated to the suprastructure or infrastructure? What is regarding the prognosis? Which part is more dreaded?
Suprastructure, tumor
right, as because it is more close to the skull base, the suprastructure part is more dangerous than the infrastructure part. So this is regarding, you can see the suprastructure and infrastructure part of the maxillectomy. And then after, I am not going into the surgical dexterities. The approach can again be, incision can again be depend on the either Moore's incision or the Weber-Ferguson incision or the midfacial deglobing. So now another area that has been frequently asked in the examination is the total maxillectomy part. Question to Shom. So what are the indications for doing total maxillectomy? Grossly total, we have discussed about medial maxillectomy for limited lesions, suprastructure and infrastructure maxillectomy. So what are the indications for doing total maxillectomy?
Sir, advanced cases of CX maxilla.
Exactly. So advanced cases of CA maxilla, when the hexagonal structure of the maxilla, the entire walls are getting involved and it is not possible to preserve the maxilla by having a clear-cut margin from the tumors. Very good, very well answered. Then comes. So then again the question will be, what will be your approach for doing total maxillectomy? What will be the incision planning? Will the Moore's incision suffice?
Extended
Moore's incision.
Extended Weber Ferguson.
Extended?
Weber Ferguson incision.
Yes, so it's a Weber Ferguson incision. Can pass the mic to another you. So what are the different extensions? Oh no, intern. So what are the different extensions of the Weber Ferguson incision? There are certain extensions depending on the extension of excision or the extension of the resection you need. Suppose you need a craniofacial dissection with the maxillectomy, then the extension is called the
subserial extension.
Subserial is for the maxillectomy. And for the craniofacial dissection, it is the extension Lynch-Haworth extension. And for more lateral extension, it is the Diefenbach extension. So you can see the Lynch-Haworth extension in the yellow line and subciliary extension in the blue line. So again, then pass on. to the next one. So now tell me very, very common and practical questions. You made the incision. What are the precautions you will take while elevating the flap? You will elevate the flap. So what are the incision? You have made the incision, splitted the lip. And now you will elevate the flap from the anterolateral wall of the maxilla. What are the precautions you will take? And what are the structures that are inevitably going to be damaged? Anyone?
Infraorbital nerve damage.
Right, infraorbital nerve is getting damaged, and the
orbital and periorbital.
what about the soft tissue elevation? It should be in a subperiosteal layer. Till the level of our lateral extension we need during the resection, for the resection. Next one. So another important structures one might take into consideration while elevating the flap. একটা vascular structure থাকে, ligate করতে হয়, নাহলে প্রচুর bleed করে. Angular vein, right, in the superior part, and in the inferior part এখানে থাকে, এখান দিয়ে cross করে. Motor vessel, it's the facial artery. So number 1 is the angular vein and number 2 is the facial artery. So now you have elevated the flap, exposed the area. Now come the main questions that are almost every one of you who have given the specimen of maxilla will be asked. What are the bony cuts? তোর ভাগ্যেই জুটেছে বল, what are the bony cuts? মনে থাকবে. Next one, ball.
Sir, first cut is malar cut.
So you need to see. So how you can remember the cuts. So you always take the extension of the tumor. Take in mind that what is the extension of the tumor. So it's an hexagonal structure, the maxilla. You need to cut it from all around so that you can have a healthy margin. So it has a lateral extension. I should start from medial. It's a medial extension, inferior extension, then lateral extension, then inferior extension and posterior extension. So tell me. আচ্ছা তুই তোর মতো করে বল, তুই যেরকম ভাবে মনে রেখেছিস।
স্যার যেটা আপনি বলছেন যে zygomatic process cut.
Very good. So zygomatic maxillary buttress, okay.
Then I will give cut at the naso frontomaxillary line.
Okay. Frontonasal process of the maxilla. Then two cuts.
Then palate cut.
Palatal cuts, 3 cuts. এখনো লেগে আছে, এখনো সরবে না।
পিছনে হচ্ছে pterygoid plates আছে।
pterygomaxillary disjunction. Which instrument is used? এটাও জিজ্ঞেস করে। ওই যে পেছন দিক থেকে বলছে। It's a carved osteotome. And one carved osteotome is used to এখনো লেগে আছে, চারটে হচ্ছে, এখনো লেগে আছে, এখনো পুরোটা হয়নি।
আর একটা ফ্লোরে আছে orbit.
Floor of the orbit. So to start with the frontonasal process of the maxilla, the incision being extended to ethmoids, then to the floor of the orbit, keeping care of the contents of the orbit, then the zygomatic-maxillary buttresses, then through the palate, and finally the pterygomaxillary disjunction. হয়ে গেল specimen now. একদম profuse bleed করছে. Which is the source? পরের জন. You remove the specimen and then there is a profuse bleeding. Which is the offending artery? শেষ, time শেষ.
Internal maxillary.
আচ্ছা specimen. 10 মিনিট হয়ে গেল. Which is the artery? খুব commonly. Internal maxillary. How will you control it? Yes, it is the compression. In most of the time, it is controlled by compression. So, to conclude it, I have discussed the cut. So, this is the specimen of maxilla. সবার ওখানে পক্ষে দেখা মুশকিল. So, how to describe a specimen of maxilla? Anyone will like to volunteer? Or should I proceed? So, it's a wet mount preparation of the maxilla. আচ্ছা ওইখানে ইয়ে করছে। It's a wet mount preparation of the হ্যাঁ আচ্ছা আমি বলে যাই প্রজেকশন ততক্ষণে করুক। So it's a wet mount preparation of the maxilla, antemortem maxilla. Okay, having its how many processes are in the maxilla? Shreya, কটা process? Frontonasal process, zygomatic process, palatine process. কোনটা বাদ যাচ্ছে? Alveolar process. ঠিক আছে? So these are the process. So these are the landmarks by which we can identify this is the maxilla. And Govindo, আর কি দিয়ে বুঝবো এটা maxilla bone? It is containing with all around the processes, it is having the sinus inside, maxillary sinus inside with the tumor. So to describe a specimen of maxilla, you will tell that it's a wet mount preparation of the antemortem maxilla. Mention the side. So how will you ascertain the side? two of the processes you should look for. Frontonasal process of maxilla to oi dikeo ache. Two of the processes you will look for. One is the zygomatico-maxillary process, another is the palatine process of the maxilla. So two of the processes you look for, and then you will comment that whether it's a right or left side. Ekhane right sided maxilla ache. Can dekhi? Yes, you see that? Right, brilliant. So this is the anterolateral wall of the maxilla. So the processes, this is the alveolar process. The frontonasal process here has been broken. This is the zygomatico-maxillary process or buttress, whatever you may see. In the medial side, turn it medially, and now see, this is the maxillary sinus inside. Okay, this is the palatine process, and superiorly will be the maxilla. And sometimes a cut section of the inferior turbinate may be attached as well. So this is how you can see that the palatine bone is situated to the opposite side, that is to the left side, and the zygomatico-maxillary is also to the opposite side, that is meant towards the right side. So this is the right sided maxilla having the maxillary sinus with all its processes and the tumor inside. I think the cuts has been described. I think this is it. এর থেকে বেশি কিছু নেই, এবার TNM staging পড়ে না. That's it. Thank you.
Thank you, Dr. Devabrata. Just there will be some questions and answer based on this session, which will be shared in the group questions, and after 2 days or so we'll share the answers so that you can make your own answers of the questions, and then we will if there are any doubts the answer solution will be also given. Sheshkar,
So please don't go away because we are running late. We have a short but important session after this. Dr. Doipan Mukherjee and Dr. Ritu Seth will conduct the session for you.
So in this session, if you are having any gray area from anyone, so you can ask 1 or 2 questions right now.
So in case of while diagnosing or while seeing the CT scan of a PNS, how will you be diagnosing the ONOD cell in which segment, in which axial section, and which section of the CT scan?
Actually, you just go behind from anterior to posterior in the coronal cut, okay? In the coronal cut, and when you are in the level of the choana, okay, you can see the pterygoid plates, that means you are at the edge of the choana, and there you will able to see the sphenoid. Now, any cell which is at the level of the sphenoid posterolaterally, overriding the sphenoid posterolaterally, but it is a part of the posterior ethmoid, okay? So that is the ONOD cell. So you have to go a little bit posteriorly. Place yourself at the level of the posterior ethmoid and choana. You can see the pterygoid wedge. You can identify the sphenoid sinus, and thereby there is a cruciate thing, a cross-like thing. Okay, any horizontal line which is above the level of the sphenoid sinus, but above superolateral migration of the posterior ethmoidal cell. Okay, overriding the sphenoid sinus. That is what we call as the ONOD cell.
So we'll be seeing in all the 3 scans. So all the 3
we can see, but ideally for you it is better to see in a coronal cut.
Coronal cut. Okay.
Sir, please proceed.
I have a question that regarding maxillectomy, what will be the decision regarding orbital exenteration required or not during maxillectomy? Sir?
So your question is whether orbital exenteration is needed or not.
No,
that will be ascertained from the preoperative scans.
Yes, sir.
How much extension is inside orbit, but prior doing orbital exenteration, you must check the visual field and the visual acuity. What sort of vision is there? If the vision is there, you must always preserve the orbit, preserve the globe. Okay, and if the disease has damaged the vision, then you need to remove it. Okay. Is that your answer you are looking for, or your question is different one?
Sir, actually, what are the radiology will suggestive of?
Radiology is the CT scan. There is in the MR probably there is gross infiltration of the tumor inside the orbit. There is involvement of the optic nerve. Those are the findings that will give you the idea that the patient needs the orbital exenterations.
Sir, one more question, sir. Sir, is there any important topics about rhinoplasty?
Rhinoplasty topic will be discussed later on. This is not the part of discussion of this right now. Okay.
So rhinoplasty, is it important in viva and theory? Viva or theory?
Yes, rhinoplasty is mostly of a theoretical. So you will be asked in your practical viva examination, you rarely will get a chance of, you will face the questions of rhinoplasty. If you have the questions of rhinoplasty, you have probably secured 70% or more than that. In grand oral. In grand oral.
We'll discuss.
This is an important topic, but as because our discussion is mainly focused on the oral and practical examination, that's why we are not discussing the rhinoplasty.
Sir, anything about septal surgeries?
Septal surgeries? Not really. No. We are not taking because those are not relevant. See, if you go for the entire 10 years, I should say, we cannot finish it up within 2 days. It includes the pituitary, it includes the cochlear implant, it includes rhinoplasty, it includes the free flaps, head and neck, and all the parts. So what we are trying to do is that we will try to focus our discussion based mainly on the long case, short case, and your practical examinations. Okay.
Any queries you have, please put it in, post it in the group, WhatsApp group. Our faculties will give the answer. And with this, we are concluding this session. Please don't go outside till we finish the inauguration. After that, there will be lunch break. You can take your break on that time. I request Dr. A.M. Shah sir and Dr. Dulal Basu sir to hand over the certificate to Dr. Amitabh Rai Chaudhary sir. Dr. Doipan Mukherjee. Sir, please. Sir.
আরো অনেক আছে
Dr. Sanjay Ghosh. Dr. Sanjay Ghosh. Dr. Moinak Dotto. Dr. Moinak Dotto, Dr. Robi Hemron. And
Dr. Devabrata Das.
ঠিক আছে দেবো পরে দিয়ে দেবো
কেন এটা দিয়ে দে না ওকে ফটোটা তো উঠে যাও
ডক্টর দেবব্রত দাস